Welcome back. We are continuing to our next module. We are going to look at the kind of monitoring that needs to be done, routine monitoring when patients are taking ARVs, and also interpretation of viral loads leading to the need for regimen switches or changes. Routine monitoring, firstly, we really want to minimize the number of tests that are done. Mainly is because blood tests can be overused most of the time, leading to budget depletion and so on. However, routine monitoring is very important because we are able to assess whether treatment is working, but also whether our patients are experiencing any significant side effects, right? So if I can just get my pointer right. So what you have is the timing from ART initiation, month 3 on ART, 6 months on ART, 12 months on ART, and then what needs to be repeated annually. Firstly, for patients who are taking TDF, we have to do a baseline creatinine clearance in non-pregnant adults. In pregnancy, we generally do just a creatinine level. This has to be repeated at 3 months, 6 months, at 1 year on ART, and then annually, right? This schedule is based on an assumption that the results would come back normal. If the results come back abnormal at any given time, we might have to repeat the tests even before the scheduled time. A creatinine clearance is abnormal when it is less than 50, and we recommend that such patients are not given tenofovir. South Africa has moved, and our preferred method of monitoring patients or treatment success is a viral load versus a CD4 count. So the recommendation is that patients should receive a baseline CD4 count and then the repeat CD4 count at 12 months, right? Later, a CD4 count can only be done probably when you have a patient who is sick and you want to determine their immune status to kind of like determine whether they're likely infections. But most of the time, repeat CD4 counts are only indicated when we have to start or even stop ART prophylaxis, specifically cotrimoxazole prophylaxis therapy and fluconazole prophylaxis therapy. The viral load, there's no recommendation for a baseline viral load. The first viral load is done when a patient has taken ARVs for 6 months. If it is suppressed, we repeat it again in 12 months' time, or when the patient is 12 months on ART. If it is suppressed, then we will repeat the viral load annually. So it is our preferred monitoring test for patients taking ARVs. Total cholesterol and triglycerides. We used to do baseline tests. In the current guidelines, the recommendation is not to do a baseline cholesterol test, but to do the first one and only test at 3 months. Then we will use that test to determine who needs to be given treatment to control cholesterol, especially if their cholesterol is more than 6. Lopinavir, ritonavir would be contraindicated, and atazanavir with ritonavir would be the best option to give our patients, right? So the ultimate goal of initiating ARVs in HIV positive patients is to reach a state where the viral load is suppressed, where we limit the replication of the virus. That would be defined by a viral load test result of less than 50 copies per mil. We know some labs and machines are able to even give us viral loads of less than 25. But for now, for the current guidelines, we use 50 as a cutoff level. Any patient who has a viral load of more than 50 copies requires urgent attention, because if the viral load is detectable, that means the virus is replicating. We do not want HIV virus to be replicating in the presence of the drugs, because that is a huge risk factor for the development of resistance. All patients with high viral loads require thorough assessment to look at whether they are taking their drugs, are they missing doses, and why is that the case? Are they forgetting? Do they have support at home? Are there any significant drug-to-drug interactions we need to look at? The dose, is it appropriate for the weight, especially in children and patients who had adjusted regimens due to kidney failure and so on? So we have to do that assessment and help patients to adhere, and hopefully they suppress again without any need to change regimens. Again, HIV drug resistance is a reality. Some patients get it from other people, which is transmitted HIV resistance. Other patients acquire it when they are on ARVs and there's poor adherence and compliance. Their viral loads go up. HIV replicates in the presence of the drugs. Then we end up with a very resistant bug. Genetic barrier is very important, and it's one of the reasons why our guidelines are changing currently. So it is easier for HIV to become resistant to certain drugs compared to others. For example, if you look at your non-nucleoside reverse transcriptase inhibitors, nevirapine and efavirenz, they require just one key mutation. One mutation and the whole class is out. Lamivudine and emtricitabine, one mutation, the class is out, but that is generally a preferred mutation most of the time, which is why you will see that lamivudine or emtricitabine, the drug is always there in all the regimens. First line, second line, third line, will always keep the drug to maintain this mutation, which is beneficial for us in slowing down the viral replication and increasing sensitivity to some of the drugs like zidovudine. Your protease inhibitors and dolutegravir, they have a very high genetic barrier to resistance. So we don't believe that patients would easily fail these drugs. Your first belief should be that if someone has a high viral load on a dolutegravir or lopinavir, ritonavir based regimen, they've probably stopped taking the drugs. There's probably compliance issues. They're probably experiencing one or two side effects that need to be sorted out. So we've got drugs that have a low genetic barrier to resistance, and we've got drugs that have a high genetic barrier to resistance. And dolutegravir and lopinavir, ritonavir have a high genetic barrier to resistance. When the viral loads are high, we need to assess adherence. We need to review whether the patient has other core infections that are making them sick, and they are not able to take their medicines well. We need to review whether the doses are correct, whether there's any other drug-drug interaction we need to look at. Not just medical drugs, over-the-counter medicines, traditional medicines. We need to review substance abuse, the mental health of our patients. At home, is the support? Has our patient disclosed? And are we able to get someone to observe them taking treatment? And sometimes they've just failed. They've just failed. There's resistance, so they failed, and we need to do something about that. So the monitoring schedule of the viral load, like I said, it should be done at 6 months, then again at 12 months, and then annually. This schedule presumes that the results are normal, are suppressed, right? So if the results come back, your first viral load result comes back as suppressed or less than 50, we are happy. We celebrate with the patient and we say continue, being a good patient, adhering. When you need support, let us know in time, but you are doing well, right? If your viral load is more than 50, right, irrespective of the level, we have to do a thorough assessment, assessing adherence, core infections, the dosing, drug interactions, and resistance. And based on whatever findings we find on the assessment, we have to intervene, helping the patient to adhere, bringing treatment supporters to support our patients at home, seeing the patient every 2 weeks, if not every month. We're not going to say go home, we'll see you in 3 months' time. We have to ensure that the patient is supported and they are able to take their medicines, and the viral load has to be repeated in 3 months' time, right? Anyone with a detectable viral load, we assess adherence, we act on it, and we repeat the viral load in 3 months' time. This is a critical change because in the previous guidelines, we had 3 classifications: 2 months for non-pregnant adults, 1 month in pregnancy, and 3 months in children. So now we have standardized, and it's 3 months for all patient populations. You have repeated your viral load in 3 months, right? So this is now your second viral load, and it comes back suppressed. I mean, then we are happy. We are saying, well, maybe that was a viral blip, or there was just, some small adherence issues. The patient has suppressed again. We are excited. We are happy. On the extreme, if the viral load comes back and it is still more than 1,000, so now the patient has met a case definition for virological treatment failure, 2 consecutive viral loads above 1,000, 3 months apart, we have to review then the regimen. What regimen is the patient taking? If this is an NNRTI-based regimen where the patient is taking either efavirenz or nevirapine, we have to stop this regimen, ensure that adherence has been resolved, and consider switching the patient to a second line alternate beta regimen, right? If your patient has 2 consecutive viral loads, more than 1,000, 3 months apart, and they are taking a dolutegravir or a lopinavir, ritonavir based regimen, we have to consider switching only if the patient had been on these 2 drugs for more than 2 years, right? And during that 2-year period, we have at least 3 consecutive viral loads above 1,000, right? But sometimes we are not treating test results, right? We have to treat patients. So if a patient has a high viral load on these drugs and the patient is clinically decompensating, has got the treatment failure, the CD4 count is declining, the patient is developing opportunistic infections, we are not going to wait for 2 years. The patient would be gone by then, right? Therefore, there would be an indication to review the ART regimen and switch the patient appropriately, right? So the switching this time around, in terms of this new guideline, right, is determined by the type of regimen that the patient would be taking. This is the modern world. We're trying to increase access to results, not just for graphs, but for action, right? So the NICD, the National Institute for Communicable Diseases, has made available a platform, an app, a dashboard where you can register and you're able to get alerts when 1 or 2 of your patients has a high viral load. You're able to export and analyze and identify patients with high viral loads and then call them in, help them assess and act on those high viral loads. One of the reports, a patient register would look like this with all these high viral loads, right? No patient should be roaming around with a high viral load when they are on ARVs. Our goal is to ensure that all patients are suppressed. Now, once you have confirmed treatment failure for adults and adolescents, the progression would be that, it's a generic progression, but time and again, it might not be like this. But if a patient is taking an NNRTI-based regimen and we have confirmed that they are failing, the next best switch is to switch them to a dolutegravir-based regimen, right? But there's 1 or 2, 3, 10 patients where DTG would not be the best option, either because they have TB, they have other drug interactions, taking anticonvulsants, supplements, women in their first trimester, and your lopinavir, ritonavir-based or your PI-based regimen would be a best option, right? So just remember, some patients would be taking DTG as a first line. When they fail that, then we might have to give them a PI-based regimen. So what do the regimens look like, right? The regimen that you are switching your patient to is determined by the current regimen the patient is taking. So if your patient is on an NNRTI-based regimen, that means they're taking efavirenz and nevirapine in their regimen. There is no need for resistance testing, right? But we have to assess their hepatitis B status because there is a need to interrupt tenofovir. Anytime where there's a need to interrupt tenofovir, we have to review the hepatitis B status of the patient, right? So if hepatitis B is negative, right, then the switch is simple. We stop tenofovir, we give zidovudine, we maintain lamivudine in the regimen, and we stop your NNRTIs and we give dolutegravir, right? If there are contraindications to using dolutegravir, then lopinavir, ritonavir would be your choice for that patient, right? If hepatitis B is there, that means we are unable to stop TDF, right? So TDF will be maintained in the regimen to keep control of the hepatitis B infection. We add zidovudine, right, with lamivudine, and we replace efavirenz or nevirapine with dolutegravir, right? There's an important concept about dolutegravir being used in second line, right? You always need to have at least one active NRTI, right? One active NRTI. So if you look at this regimen, we presume that TDF is already out. There's some resistance against lamivudine, emtricitabine. We believe there's some resistance against it, right? And if we are going to give DTG, we need at least one active NRTI in that regimen, right? Where you cannot give DTG because of drug-drug interactions and stuff, you use lopinavir, ritonavir. But you would see, when you use lopinavir, ritonavir as part of the second line, it's not a requirement to have one active NRTI. Therefore, this patient with hepatitis B, we can treat them with tenofovir, lamivudine, and lopinavir, ritonavir. Clinical outcomes for these two patients are relatively the same. When you have a patient who has been on a DTG-based regimen for at least 2 years, remember, for at least 2 years, right? You need to discuss with an expert, because most patients might not be failing, but a resistance test might be required, right? Might be, but not always, right? So if someone is failing a DTG-based regimen, right, our option is to give them a PI-based regimen, right? So you would stop tenofovir only after checking their hepatitis B status. So if the patient does not have hepatitis B, it's an easy switch. TDF, you replace it with zidovudine, you maintain lamivudine in the regimen, you replace DTG with lopinavir, ritonavir. If your hepatitis B status is positive, right, we would then, that means we have to maintain TDF in the regimen, right? Lamivudine must also be maintained, because these two drugs together also control hepatitis B, right? And we just stop DTG and give lopinavir, ritonavir. Remember, with lopinavir, ritonavir, we don't necessarily need to add an additional NRTI, right? We can control the virus with the same regimen, and here we'll be able to control both HIV and hepatitis B infection. Where a patient has been taking a protease inhibitor-based regimen for 2 years, and you suspect treatment failure, that means you've got 2-3 viral loads that are high, after intensive adherence between these viral load tests, there's always a need for resistance testing, right? We need to determine the level of mutations, and so that an appropriate regimen can be prescribed for this patient, right? So you would do a resistance test. If it comes back and says no PI resistance, it means the issue is not the virus, it's more on the adherence side of things. Then we need to discuss with the patient, look at what the issues are.
What can I do for you?
If the problem
Hi. How can I help?
if the problem is issues around side effects, especially diarrhea, the watery diarrhea that patients get when they take lopinavir, ritonavir, we might need to do a substitution, right? Make the regimen easy, tolerable for the patient. If we have confirmed that there is high level resistance to lopinavir or even atazanavir, we have to follow the national protocol of accessing third-line ARVs. So there are forms to be completed where they need evidence of the viral loads, evidence of the resistance profile. We send it to the National Department of Health. The third-line committee, a group of experts, would sit, review your patient, approve a combination of drugs, and these are released on a named patient basis. That means they will come and say, these are drugs for Lesotho. You cannot use them for John or even Thomas, right? Those are regimens for adults. Coming to children, almost a similar approach, except that as always with children, we have to look into issues of weight. So if a child is taking an NNRTI-based regimen like efavirenz and they are failing that regimen, we have to assess their weight, right? Because children are only eligible for dolutegravir when their weight is above 20 kgs. So if someone is failing, a child is failing efavirenz-based regimen, you have two options. Either you give them lopinavir, ritonavir, or dolutegravir based on their weight, right? If their weight is less than 20 kgs, lopinavir, ritonavir would be the best option, right? And if their weight is above 20 and they are failing lopinavir, ritonavir, you could easily give the child DTG, right? If they are failing DTG-based regimen, you could easily switch the child to a lopinavir, ritonavir-based regimen. Resistance testing is always required in children who are failing either DTG or lopinavir-based regimen. We need to confirm that these kids are truly failing these regimens. So what do the pediatric regimens look like, right? Basically, the main thing is to discuss with an expert, even if you know nothing about these regimens, right? Try to get someone to call. You can also call me. We can try and discuss. I also know a few specialists, infectious disease specialists, very experienced clinicians, which I can link you with. These are very difficult decisions to make on your own, especially when it comes to children, right? But like adults, your second line regimen is determined by the type of regimen the patient is on. So if they are on an NNRTI-based regimen, that is an efavirenz nevirapine-based regimen, right? Resistance testing is not required. You have to check the child's weight, right? If the weight is less than 20 kgs, you can then probably use lopinavir, ritonavir. So zidovudine, lamivudine, and lopinavir, ritonavir would be your options, right? If the weight is above 20 kgs, right, that means the child is eligible for either DTG-based regimen or a protease inhibitor-based regimen, right? The decision between the two is whether you have one additional extra NRTI that's active or not. If you do have an NRTI that was not used, the child has never been exposed to, then you can give DTG, right? For example, a child who's failing abacavir, lamivudine, and efavirenz, and they've never been exposed to zidovudine. That means you can give zidovudine, lamivudine with DTG, because zidovudine would be that one NRTI presumed to be active. Where you do not have, right, any available active NRTIs, then lopinavir, ritonavir should be your option with two other NRTIs, right? If a child has been taking a PI-based regimen for 2 years, lopinavir, ritonavir for 2 years, and they've got high viral loads and you believe that they're failing, we have to do a resistance test, right? If resistance is confirmed, we have to refer to a third line committee excuse me, at the National Department of Health, right? If no PI resistance has been confirmed, then we need to look at the weight. If the weight is less than 20 kgs, we are just addressing adherence and saying, hey, you need to adhere. If you take your treatment properly, things should go well, right? If their weight is above 20 kgs, we have to consider switching them to DTG if we have at least one active NRTI, right? This is because this would be a simpler regimen for them, and it will deal probably with some of the Side effects that would make patients not to take lopinavir, ritonavir, especially taste, issues around diarrhea, and so on, right? Otherwise, there's still an opportunity to continue lopinavir, ritonavir because we couldn't confirm resistance, and we need to therefore support patients and ensure that they are adhering, right? Where a patient has been on a dolutegravir-based regimen for more than 2 years, we need to do a resistance test, right? It's a requirement. If we confirm resistance, right, we have to refer that child to the third line committee to look at the third line ART regimen for this child, just to be sure, right? If the resistance has not been confirmed, generally we believe that this is probably because of poor adherence, and then we have to review the 2 NRTIs that the child is taking. If they are both active, we just continue. If one of them is down, let's say we get high level resistance to abacavir, you might as well then give them zidovudine, lamivudine, but you still keep DTG there because resistance was not confirmed, right? Where you cannot confirm, the results come back, they say abacavir, high level resistance, zidovudine, high level resistance, and the child is not yet 35 kgs. Remember, you can't use TDF in children with weights below 35 kgs, right? So you are not sure what to do with your NRTIs. Please don't spoil our DTG. Discuss with an expert, refer the child to the third line committee, and let us come up with a better regimen for that child. Right, that's it with monitoring patients on ART. Remember, DTG is an important drug. It is changing our guidelines, totally, because we want to have a strong first line ART regimen, because DTG has a high barrier to resistance. It's got, like any drug, it's got side effects, but these side effects are not common, right? And most of which are minor. There is a signal for some teratogenicity. We just need to pay attention, ensure that women are on appropriate family planning drugs and so on, and that they are empowered to make appropriate decisions. Virological suppression is now defined as being less than 50. We used to use 400, it's now 50, right? We want all our patients to be suppressed. Where the viral load is high, we have to assess, we have to intervene, we have to repeat the viral load and confirm whether the patient is failing or not. Never introduce one drug into a failing regimen. You will be compromising future options for your patient and compromising their regimens. If you have to do a single drug substitution and you have a recent viral load that's suppressed, you may switch. However, if the viral load is anything more than 50, the recommendation is don't switch. Please don't switch, right? Deal with failure. Decide whether this patient is failing or not. We do not introduce one drug into a failing regimen. When patients have high viral loads, they need to be assessed. We need to review. We need to take action and ensure that they are suppressed. As soon as the viral load goes beyond 1,000, we should consider switching our patients to second line ART therapy, right? Resistance testing is indicated for patients failing PIs for more than 2 years, or children who are failing a DTG based regimen. Thank you very much for your time. I hope this was very valuable. Hoping to see you again in our next module. Be blessed.